So we'll start then with growth hormone, and we'll talk a bit here about how the growth of the bones happens. You've seen this before, but just to go through it again, we have a younger bone here shown on the right, and then we have this sort of dotted line that is a superimposition over this older bone. And this is basically to show you how the bones grow. They grow longer, and they grow thicker, and they grow wider. And this is because new bone is placed down as cartilage here, and older bone is then taken away, and you get bone put down. So you have this sort of cycling, this modeling of bone being placed down as cartilage and the older bone being taken away, and this is due to the actions of osteoblasts that lay down the bone, and then osteoclasts take it away. And sex hormones have the effect of closing this epiphysis that then prevents further bone growth, and this is why you don't grow anymore after puberty. And this is also why men tend to grow taller than females, because they have a longer period for these long bones to elongate before puberty then comes, gives you a growth spurt, but it shuts off these epiphyses, so you have no more cartilage laid down, you have no more elongation of the bone. And this whole growth is stimulated by growth hormone through the effects of IGF-1, which is released from the liver, but it's also released from the bone plates and other target organs that are stimulated by growth hormone to release IGF and increase the number of receptors for IGF that then stimulates this growth I just talked about. It's worth remembering the control of growth hormone release from the hypothalamus pituitary target organ axis. In this case it's the liver and the bone. So the hypothalamus releases growth hormone releasing hormone that then stimulates the pituitary to release growth hormone that then affects the target organs to release somatomedin, or otherwise known as IGF. And you'll notice that these hormones that are released from the different places all feed back negatively on the different organs of this axis, so you have a large amount of feedback loops all over the place. Growth hormone releasing hormone will stimulate the inhibition of its own release. Sorry, I said that. So it will inhibit its own release. Growth hormone will also inhibit its own release from the hypothalamus via inhibiting the release of GHRH, and then somatomedin will also come back and inhibit the release of growth hormone, releasing hormone and growth hormone from both the hypothalamus and the pituitary. And this then gives the whole system a large amount of control through this negative feedback. Also notice what stimulates the production of growth hormone releasing hormone and thus growth hormone: serotonin, dopamine, alpha adrenaline, stress and sleep. These will stimulate the release of growth hormone, and then conversely beta adrenaline, high blood glucose, high free fatty acids, the well-fed state. This inhibits growth hormone release and thereby can affect growth. So this is growth hormone control simplified. Again, we have growth hormone releasing hormone stimulating growth hormone release that works on the bone and the liver to stimulate IGF-1 that then stimulates growth via the bone, but then also growth hormone will stimulate somatostatin, which then inhibits its own release, and also IGF-1 will stimulate somatostatin release, which will also then inhibit the release of growth hormone from the pituitary. And there are therefore lots of feedback loops to keep a good control over this whole system. So this graph shows the overall effect of growth hormone, this figure rather, and growth hormone stimulates growth through the actions of IGF-1, but it also has specific effects on many organ systems, and in those places it stimulates chondrocytes to mature, and these chondrocytes will release IGF-1, stimulate growth. What growth hormone does on these chondrocytes is upregulate amino acid uptake and protein synthesis, chondroitin and collagen synthesis, and it increases the cell size of number, and then this promotes linear growth, and these chondrocytes will release IGF-1 to have a paracrine effect on the organ these chondrocytes are contained within. Growth hormone will also stimulate metabolism by increasing plasma glucose and plasma fatty acids, but reducing plasma amino acids as organs are stimulated to take up amino acids to create proteogenesis. In the muscle, glucose uptake is reduced, but amino acid uptake is increased, and this increases protein synthesis, and so your lean body mass increases. Adiposity is reduced as lipolysis is increased to supply the energy demands for protein synthesis of the different organs. And as we can see here, the kidney, the pancreas, the intestine, the islets, parathyroid organs, skin, connective tissue, bone, heart and lungs are all stimulated to increase protein synthesis, increase nucleotide synthesis and increase cell number, and this will then increase all these organs size and all these organs function, and it all comes down to the central effect of growth hormone on these organs. So when it comes to the failure of a developing individual to grow, it's called pediatric failure to thrive, and there are a number of reasons of this, and it's just characterized as the inability of the person to grow normally by accepted growth charts by the CDC. And it can be due to a large variety of organic causes: inadequate dietary intake, abnormal absorption of food, abnormal losses for the GI tract, or inborn errors of metabolism that prevent the use of your nutrients and the lack of normal growth as a result. But it can also be due to non-organic causes, such as dysfunctional relationships, abuse, and things like that cause emotional deprivation, and these are thought to occur then due to endocrine dysfunction as a result of that. I showed you how growth hormone is released from the hypothalamus and the pituitary axis, and then these sort of non-organic causes that causes extreme stress then can cause a dysfunction in the release of growth hormone that then results in the failure of the individual to thrive. And so sleep deprivation or abnormal sleep patterns can then disturb this release of growth hormone, leading to the pediatric failure to thrive. And this is because growth hormone exhibits a diurnal rhythm. It has a circadian release, and as this circadian rhythm is disrupted, so is the release of growth hormone. As we see here, this is the release of growth hormone. Shortly after going to bed, this is when this major spike of growth hormone happens, but then you get these pulsatile releases of growth hormone during sleep, and this then stimulates growth, and if this is disturbed, then also your growth will be disturbed. When it comes to examining the release of growth hormone in an individual, particularly in patients who fail to thrive, you would stimulate the release of growth hormone using different agents, so L-DOPA, as a stimulus for growth hormone release, and arginine is amino acids that also stimulate growth hormone, and then clonidine is a alpha adrenergic, so it was stimulus, and propranolol then is a beta blocker, which will stimulate it through preventing beta adrenergy, and insulin will also stimulate growth hormone by lowering blood sugar, and hypoglycemia will then stimulate the release of growth hormone. These are some of the things that clinically are used to stimulate growth hormone, and then it'll allow you to test whether the body is able to release it, and it'll get at possibly some of the conditions that are affecting the patient's failure to thrive.